Good afternoon. I'm Dr. Bhuvaneshwari, consultant neurologist and neurophysiologist. We are facing a pandemic, COVID-19, which started in China in the Wuhan city, Hubei province, and it has become a world pandemic now. Initially, it actually shook the world, shocked the world. There were patients getting really sick, and doctors were completely shocked to see patients becoming so sick, requiring ventilators, dying, young patients dying. So there was a lot of panic around the world, and the healthcare system was being challenged in every possible way. And then slowly, as time evolved, knowledge evolved, doctors all around the world and from the experience that we were getting from other parts of the country and the world, we started learning and we started formalizing a treatment regime. And slowly, we are understanding this coronavirus better. We are understanding the pathophysiology here, the various respiratory manifestations that a patient can come to you with, and also how to deal with these patients, whether they have asymptomatic, whether they have mild infection or moderate to severe infection. Now, the main problem again that we are having right now is that coronavirus need not present only with respiratory problems. Patients are also coming in with strokes. They're coming in with cerebral bleeds. So we start to wonder what is happening. Is coronavirus causing these problems? What are the neurological manifestations of coronavirus? This has become a huge point of interest for many doctors across the world. And likewise, we at Kauvery Hospital also were interested to know what was happening to our patients, whether we were seeing an overwhelming number of patients with neurological manifestations, or where these symptoms, some of the symptoms especially, are more an epiphenomena or a phenomena that you see with any sepsis, or is it directly linked with the infection. So today we are going to be talking about this problem, and I just wanted to share the knowledge that we have gained from the studies done across the world, and also the pattern of problems, neurological problems that we have seen at Kauvery Hospital. And also, I just wanted to share details about a few patients who were quite interesting, and I thought we should share this detail with everyone. So, we know that coronavirus is a very novel SARS-CoV-2 virus. It's a single-stranded RNA, and it causes severe acute respiratory syndrome, and that's why you have so many problems, patients having respiratory issues. Now, what are the symptoms that these patients are coming to you with? And if you look at the symptoms, typical symptoms include fever, anosmia, headache, cough, diarrhea, dyspnea, that is breathing difficulty, which usually starts about 5 to 8 days from the start of the fever or myalgia or headache. You can have, of course, pneumonia, lymphocytopenia. When you look at the complications of this infection, patients have acute respiratory distress syndrome, secondary infections, cardiac injuries, acute kidney injuries, and of course the CNS manifestations. Now, anosmia has drawn a lot of interest as to whether it is some kind of predicting feature of coronavirus, whether it is actually a problem that we can detect early, whether it's giving you answers as to whether this patient is going to develop severe infections, or does it actually indicate a milder infection. Now, when we look at the various symptoms of corona and the median duration of how the infection happens, most of the times the cough and the fever takes about 5 days from the time of the virus actually entering the body. And the breathing difficulties, it takes at least 5 to 8 days before the patients start to have some kind of respiratory distress. And then, of course, 10 days to 12 days before they start showing signs of lung injury or lung involvement. And this is a fact known to many of the specialists who are involved in treating coronavirus. Now, if you look at the treatment that we are following in Kauvery Hospital, I think there was a talk earlier, about 2 weeks ago, where they dwelled on this topic about treatment of corona. And here, the evidence-based treatment is being followed, and they are sticking to the usual, the fundamentals of treatment, which is making sure that the fluid balance is maintained, if necessary, use of diuretics. They are using blood thinners, dalteparin, and there are various dose regimes that is being followed. If it's a prophylactic dose, it is 5,000 units once a day. If it's treatment, then 7,500 units subcutaneous dose 2 times a day. They are also giving dexamethasone, a small dose, especially if the respiratory symptoms are seen and if the patient is requiring or increasing levels of oxygen. And of course, as you all know, proning the position is very, very important maneuver, which is actually brought on a big change in the treatment of these patients. Using antivirals and tocilizumab is being recommended, but the evidence, the strong real evidence for the use of these antivirals is still a little debatable. There's a lot of deliberation still going on as to whether these medicines are required for every patient or are to be reserved for certain patients. And they have very clear indications as to when the patient has to be intubated. So if a patient is showing signs of airway obstruction or increasing signs of breathlessness and hypoxia and increasing level of CO2, or if they are developing encephalopathy, then of course patient is intubated based on the other clinical circumstances. Now, we'll come to our topic, which is COVID and COVID-19 infection and neurological manifestation. Now, the common neurological manifestations that people are talking about is the anosmia. Now, this, as I told you, has drawn a lot of interest. Headache. Patients complain of dizziness. There is altered mental status. So, they are a little bit confused, disorientated to time and place. Patients can also have seizures, first-time seizures, new onset, adult onset seizures we are seeing in patients with COVID infection. And of course, there's a lot of myalgia. Now, if you look at the serious manifestations, of course, encephalopathy, so extremely drowsy patient. They can also have a hemorrhagic necrotizing encephalopathy that changes. So if you look at the scans, they will have typical changes in the basal ganglia, and they will require immunotherapy as part of their treatment regime. They can show signs of encephalitis, myelitis. The patients do present with CVA, both thrombotic and hemorrhagic. And we also have had patients who have actually presented with GBS-like neuropathies and severe ataxia. Now, let's actually look at how this virus is causing neurogenic manifestation. Now, are we saying coronavirus is directly causing these neurological symptoms, or is it an epiphenomena? Is what my question is. So, when you look at the virus itself and how the virus actually attacks the body and the changes that it brings on in our system, you know that coronavirus is not primarily a neurotropic virus. It is not. It's real manifestations are mainly respiratory, sometimes cardiogenic. But of course, as I said, we are seeing neurological manifestations. So how are we thinking this virus is entering the brain? So there are theories. One is through the nasal receptors. So here the anosmia plays a big role. So when we talk about anosmia, what is happening to these viruses? How are they entering the brain through the nasal receptors? So is the ACE inhibitor receptor playing a very big role in the entry of the virus into the brain through the nasal receptors? You can also have virus entering through retrograde synaptic transmission through the sensory nerves. And is there a breakdown of the blood-brain barrier? Is there a hematological spread of the virus to the brain? So there are a lot of questions, and there's a lot of research that's happening in this area. We need more knowledge, and because knowledge is evolving, and there is no real clear-cut evidence as to which is the real pathway of entry for these viruses into the brain. Now, if you look at the other problems of neurological problems, you know that it is not just directly because of the virus entry into the brain, because you can have altered sensorium or confused patients who when you have very, very severe sepsis. So you call it septic encephalopathy. So the sepsis, the hypoxia, the hypercapnia, that is the retention of CO2, all these is going to lead to altered sensorium. It can even lead to seizures sometimes. So are we saying that these neurological manifestations could also be a secondary manifestation of the primary problems? We don't know. Again, immune-mediated mechanisms are being discussed widely across. So what happens? The cytokine storm, the endothelial damage through the interleukin-6 and the T cells, raised tumor necrosis factor, the coagulation cascade disruption, extensive complement involvement. So when all this is happening, is that causing increased coagulation issues in the body, leading to highly coagulable blood and then indirectly leading to thrombotic phenomena and CVAs and cardiac problems, because this breakdown of the coagulation cascade can lead to increased thrombosis. So again, this immune-mediated reactions can be both acute as well as late. So as I told you, this hypothesis, they're all there. We are looking at all these hypotheses. We do not have a clear evidence as to what exactly is causing the problem. Of course, we have to bear in mind all these issues, all these mechanisms that we discussed, whether it's direct entry of the virus into the brain or indirect effect on the brain through hypoxia or hypercapnia causing issues, or is it the immune-mediated response? So all these mechanisms have to be borne in mind when we are dealing with patients with neurological problems. Anosmia and loss of taste, the ageusia. So they go hand in hand. And if you look at various studies where patients with anosmia have been followed up and studied for a longer period, they found that almost anosmia is a symptom that patients come in with, and the percentage can vary from about 30% to almost 70 to 75% of the patients with COVID infections having anosmia. It's a very, very strong and important symptom that the patient complains. And when you look at the population of patients with COVID who are actually reporting anosmia, there's a high female preponderance. And what actually is the basis for this? Again, there is lacking evidence there. So what happens? Why is there anosmia? Is there destruction of the epithelium, nasal epithelium? Is there dysfunction, olfactory dysfunction because of the nasal congestion? Is this the point of entry for the virus into the brain? Again, as I said, a lot of questions. and a lot of studies still being carried out, and there has not been a single right answer for any of these questions. However, what we have seen is that usually anosmia comes around 4 or 5 days from the time the virus enters the body, and the anosmia can stay for the patient for about 20 to 21 days during their entire course of illness. And many patients with COVID infections who have recovered have actually said their sense of smell has actually returned, which is very good sign. So, is anosmia an indicator of good prognosis, or is it an indicator of bad prognosis? Now, many a times patients who present for the first time with severe respiratory distress are unable to report anosmia. We are not in a position to ask them questions about anosmia. So it becomes very difficult to make this documentation as to find out whether all patients with severe respiratory involvement, whether they do have anosmia or not. We need more data for this. When you look at Kauvery data, how our patients are manifested, we have actually come across with proper neurological manifestation. See, when we looked at the patients, we did not include patients with myalgia, we did not include patients with headaches, because headaches and myalgia seems to be an epiphenomena rather than a unique problem of coronavirus. Because we have seen patients with any flu-like illness complain of headaches and myalgia. So it is very, you have to be careful before saying these are unique problems of COVID-19 virus. But when we looked at our population, many of our patients with COVID infections had altered sensorium. So they were slightly confused, disorientated, a little bit drowsy, but arousable. They would answer your questions correctly when aroused. Maybe disorientated to time and place, but most of the commands that you give, they will obey, they will follow what you're saying. So this was a very common phenomena that we were seeing, and if you look at these patients, the other problems that they were having at the time of examination, definitely they needed oxygen. So they were hypoxic. They were having some amount of CO2 retention. They were showing signs of sepsis. So it's, as I said earlier, again, whether this altered sensorium is more a sepsis related or hypoxia related problem or a direct influence of the virus is something that we need to see over time. And then we also came across quite a lot of patients presenting with first time seizures. Some of these patients who had altered sensorium, who became more and more drowsy, have developed seizures. And when we actually looked at their EEG, they would have slowing, general slowing in their background cortical activity, but nothing focal or nothing to suggest a typical type of epilepsy. It was more like a encephalopathic EEG pattern with liability to seizures or a reduced threshold for seizures. And there was one patient where we managed to do a CSF study because he was having recurrent seizures. In most patients that we saw with COVID infection, the seizure was like a one-time phenomenon. But there was one patient who had recurrent seizures where we did a CSF study, and the CSF showed 30 cells, so slightly raised, and predominantly lymphocytes. The glucose and protein was normal, but 30 cells, predominantly lymphocytes, and the patient was already being treated as COVID infection, was in hospital for more than 10 days when I actually saw the patient. So the question was whether this patient was just recovering from a mild encephalitis, or was this just an immune phenomena to the virus was very difficult to say. We did manage to do an RT-PCR. I mean, we did do a PCR, coronavirus PCR, and it was negative in the CSF. So there was we could not isolate the virus in the CSF as such. Then we had patients who presented with CVA, both infarcts, so thrombotic, as well as hemorrhagic strokes. Now, the thrombotic, the majority of the patients who came in with strokes were older patients with comorbidities such as diabetes and hypertension, which puts them at a risk of developing strokes and cardiac problems. So again, whether the infection has increased the risk of stroke by causing more coagulability issues in these patients is a very interesting question that comes to our minds when we talk about coronavirus. And in fact, our vascular surgeon recently talked about increased thrombotic phenomena in patients who have recovered from COVID infections. So patients who have actually gone home have come back with deep vein thrombosis or pulmonary embolism, or even mesenteric artery thrombosis and so on. So there is definitely a clear pattern evolving here, which is increased coagulation issues in patients who have coronavirus. We also saw one patient with facial nerve palsy. There was one boy who had GBS-like phenomena, and there was a patient who also presented with severe subarachnoid hemorrhage, but there was no aneurysm on the CT angiogram. So these are some of the pictures of our patients who had strokes. As you can see, they had both an infarct, so a thrombotic stroke, as well as bleed, with causing the strokes. And if you look at the CTs, the extent of lung involvement was not a true predictor of the nature of stroke that the patient was going to have. So a patient with a really bad lung may not have a stroke, and a patient with mild to moderate degree of involvement could have a very major stroke, and we might actually lose the patient. So the extent of lung involvement was not a direct predictor of what was happening in the brain. So I thought I should also just talk to you about some of our interesting patients that we came across in Kauvery. So as I told you earlier, there was this 72-year-old man, previous history of psychosis, but was in remission for a very long time. He was being treated for COVID, proven on treatment in the hospital. About a week to 10 days later, as he was getting better from the respiratory symptoms, he developed altered sensorium and developed seizures. He had 3 seizures. Initially, the first time we treated him symptomatically, because by then we had already seen a couple of patients with COVID infection with seizures. So we just treated him symptomatically. And those patients had only 1 seizure, and once they got better from the COVID infection, they did not have further seizures. So whether it was a sepsis related encephalopathy and seizure was still a burning question. And this gentleman, because he had recurrent episodes, we thought we'd go in and do a CSF. And as I told you earlier, the CSF showed 30 cells, but nothing to suggest an active infection, and it was predominantly lymphocytes. And so we concluded that perhaps this patient had encephalitis, and as the patient was getting better, the CSF picture that we are seeing right now is probably a late picture in this patient, because the patient was otherwise getting better from the COVID infection. And once the seizures were controlled, he also had some tardive dyskinetic movements. So that was also treated symptomatically. And now the patient is completely all right and all set to go home. So this was the EEG of that patient. Here you can see that there are some sharpened activity that you can see. If you look at the EEG here, the red lines denote right hemisphere and the blue lines at the bottom denote left hemisphere. And on the right hemisphere, you can see more sharpened activity than on the left. And this EEG here shows that he was having some jerky movements, and you can see that the sharpened activity on the right side is definitely increasing when he was having the seizures. So we were quite fortunate that we could actually capture one seizure when we were doing the EEG for this patient. We had another very interesting patient, a 14-year-old boy who came in with this history that he had fever for one day, a week ago, and mild loose stools just after the fever. And 1 week later, he came to us with this problem of double vision. So when you examined him, he had left lateral rectus palsy. So he was unable to abduct and look to the left. And also, when you examined him carefully, there was also some restriction of adduction, that is medial movement in the right eye. So there was complex ophthalmoplegia here. And the rest of the cranial nerve examination revealed that he had a very mild left lower motor neuron facial palsy. And he was severely ataxic, difficulty walking, and the reflexes were depressed. No other medical history, nothing of any significance here. So the presentation was like the Miller-Fisher variant of Guillain-Barré syndrome. We went on to do the CT in this patient because he was a young boy, he had fever, and we were going to admit him. So we wanted to make sure that, and we were reading literature where patients, young pediatric population, were actually presenting with Kawasaki-like syndrome with COVID. So immune phenomena can occur with COVID. So with that knowledge we went on to do the CT. And when we did the CT, it was quite interesting because he did not have any ground glass appearance. Instead, he had bronchitis like changes. Whether this was, there was some indication that some of these changes were more chronic, but the patient's parents denied any previous respiratory problems. So we were keeping an open mind on this. He went on to have the RT-PCR, and that turned out to be positive. No history of travel, no history of contact with other patients with corona infection. His anti-ganglioside antibodies were sent off and they were negative. So we immediately went on to do the nerve conduction study, which actually showed, now if you look at this is a sensory study. So take it from me, the sensory studies were all normal. But when you look at the motor studies, that is the motor nerves, this is the proximal response and this is the distal response. And you can immediately see that there is a conduction block, there's a drop in the amplitude of the response. So there was something happening to these motor nerves. And when we did the MRI of the spine with contrast, we found that there was contrast enhancement at the conus medullaris and at the radicals, which again were consistent with GVS. And you can see these pearl-like contrast enhancement on the axial pictures, and here is more. So this patient we admitted and we treated him with IV immunoglobulins for 5 days based on his weight, and we sent him home after the treatment, and we asked him to do home quarantine because he did not have any respiratory involvement. He was maintaining his oxygenation, There was no fever, no other symptoms of concern. So he went home after IVIG for 5 days with oral steroid dose, tapering dose. And let me tell you that the patient is doing very well. He came up for follow-up and walking very well. His ophthalmoplegia is better. He's got just a mild right-sided medial adduction issues, but otherwise he's able to look in all direction, no double vision as such, and walking very well. So it was a very satisfactory response to IVIG, and the patient, we're still having follow-up with that patient. And the parents, we allowed the dad to stay with the patient during treatment, and the dad and both the parents are well as well. Now, if you look at whether there are neurological conditions which could put you at risk of getting a COVID infection. See, we in neurology come across elderly patients. Most of our patients are elderly patients who are having issues like dementia, Parkinson's disease, stroke patients. Now, these patients do have underlying diabetes or hypertension. Some of them could be obese. So there are other risk factors too, but whether these neurological problems put them at a higher risk of developing coronavirus infection is again very debatable, and there's not much evidence to say that if you have Parkinson's disease, you're at a higher risk of developing COVID infection. That is not the case. We are seeing patients, healthier patients, coming in with corona infections, and many of our Parkinson's patients are doing well, touch wood. And younger patients who are on immunotherapy, so multiple sclerosis or neuromyelitis optica spectrum disorders, myasthenia gravis, and other autoimmune conditions where we have to use immunosuppressants. These patients, we have to be careful. We do give them extra advice on social distancing and maintaining all caution at home and outside to make sure that they do not get the infection. And there has been quite a lot of studies looking at the various immunosuppressants. For example, in multiple sclerosis, they looked at the regularly used immunosuppressants like your beta interferons. They looked at natalizumab and rituximab, and they found that patients who were on rituximab, which is a CD20 immunosuppressant, was actually one agent which was putting patients slightly at a higher risk of being more immunosuppressed and maybe an extra risk factor to develop COVID infection. But beta interferons surprisingly came out very clean, and most of the patients on beta interferon did not have any major problems, extra problems or extra risk of getting infected with COVID-19. And so when we are talking to our patients with these neurological conditions, we are actually telling them not to stop medications, not to try and see whether stopping medication is making them, don't experiment, no experimentations. Please continue your medication as prescribed. If you develop any symptoms, get in touch with us. So we have been following up our patients, neurological patients, with these conditions who are on immunosuppressants. And again, touch wood, none of these patients have actually had any issues. So we will continue to follow them up, and so far it's been all right. And there's also been studies to say avoid IV steroids, but oral steroids are much better tolerated. So IV steroids and rituximab somehow seems to be the two agents where you have to be careful, and if you can avoid these two, please do so. Um, so what happens after you've recovered from COVID infection? Does everything just end there? Maybe not. In fact, there are a lot of patients who come back to us later complaining of extreme fatigue, like syndrome. They are complaining of myalgia, arthralgia, joint pains, a lot of sleeping problems, and post-traumatic stress, especially patients who have been in the ICU for a very long time requiring non-invasive ventilators or high oxygen requirements. These patients are gone through a very stressful period in their lives, do suffer from some post-traumatic stress symptoms, and we have to help these patients based on their needs and requirement. And depression again is something that is seen, and cognitive impairment. Now, again, there's a lot of interest to find out if patients who have been severely hypoxic on ventilators, who have recovered, to find out whether they are developing cognitive issues. There are a lot of studies in this area. There's not been any concrete evidence to suggest that patients who have recovered from COVID infections can actually develop neurological, cognitive problems or memory issues and so on. But we need long-term follow-up of these patients to get a more concrete answer on this in this area. But it's too early for us to say much about it. But there are lots of studies happening, and we are following up our patients as well. Now, having said all these issues with COVID patients, we are also seeing our other patients who are actually coming to us with sleeplessness, with extreme stress, extreme panic, actually having panic attacks. And sleep problems seems to be a very, very common issue that everyone complains of. And they think a single pill is going to make it better. We're trying to avoid pills in most patients, trying to talk to them about sleep hygiene, trying to educate them about what is happening, and telling them there is a lot of information, or overload of information, in fact. So maybe getting too much information sometimes and may actually lead to more problems. So if you can assimilate whatever you can take in correctly, yes, it helps. But when you get affected by all this information, maybe it is important for us to keep it down and to be more receptive to this kind of information that we get. So I think that is something that we are seeing commonly in our clinics, and we are advising patients accordingly. It's more to do with relaxing techniques, non-pharmacological ways to treat these patients than medicines. So, in summary, I would like to end this talk by saying COVID-19 is still a primarily respiratory virus, mainly affecting the lungs, and it can cause flu-like symptoms. The neurological manifestations are seen in patients, and we should have high index of suspicion in patients who have COVID infection. However, we should also be very careful before labeling every symptom that the patient has as a unique or a direct issue or effect of the virus rather than an epiphenomena. But strokes and other immune related problems like the GBS and immune encephalopathies are something that we should keep in mind, even in patients who have recovered. If they have showing issues of motor weakness or confusion, we should have a very high index of suspicion in these patients, and we should evaluate these patients for immune related problems. We know that the virus actually causes changes in the brain, both cytotropic as well as immune mediated methods. But of course, we have to be very careful about assuming that there is definitely a cytotropic effect, and we'll have to wait for some time before we get more knowledge in this area. And of course, I would like to say that long-term effects of COVID infection and the various neurological manifestations, we need to follow up to get a clear picture, and then maybe in another couple of months we'll have, or a year later, we'll be more informed in this area, and we can talk more about this particular problem associated with COVID-19 infection. Thank you.